Hey everyone, welcome. Today, we're diving into a topic you're going to see all the time in clinical practice, the huge range of complications from diabetes. We're going to cover it all, from the crazy metabolic crises that land patients in the ICU, all the way to that slow, creeping damage that can affect the entire body over years.
So let's kick things off with a really practical question. Why on earth do we screen for a disease that can be totally asymptomatic for years, sometimes even decades? I mean, if the patient feels perfectly fine, what's the rush?
Well, here's the thing. The damage doesn't wait for symptoms. Diabetes has this long, silent period of high blood sugar where all the bad stuff is already starting to happen. We're talking about tiny bits of damage to the eyes and the kidneys, and bigger changes happening in the arteries of the heart and brain, all before the patient even has a clue they're sick. And that is exactly why getting in there early with intensive control is so critical. It's our best shot to prevent or at least seriously slow down this whole process. Okay, so here's our game plan for this explainer. We'll start with the scope of all this silent damage. Then we'll jump into the acute crises, the big metabolic emergencies, DKA and HHS. After that, we'll get into the long-term battles, the huge cardiovascular toll, the specific damage to the eyes and kidneys, and the really tough effects of neuropathy. And then we'll wrap it all up by coming back to proactive screening, which is our best weapon to stay ahead of it all. All right, first up, let's talk about the scope of this damage. The main theme here, the thing I really want you to remember, is silent progression. That period where the patient has no symptoms, that is not a safe phase. It's the critical window where the foundation for all the future really devastating complications is being laid.
Okay, now let's switch gears to the acute crises. Diabetic ketoacidosis and hyperglycemic hyperosmolar syndrome. This is the point when that chronic high blood sugar suddenly flips a switch and becomes an immediate, life-threatening emergency. This is where you need to be sharp and act fast.
This slide is great because it puts DKA and HHS right next to each other, and understanding the why is everything. So think of it like this. DKA is driven by an absolute lack of insulin, zero insulin signal. So the body just starts breaking down fat like crazy, flooding the system with fatty acids and cranking out ketones. That's what causes that severe metabolic acidosis. Now with HHS, there's a partial insulin deficiency. There's just enough insulin hanging around to stop that massive ketone production, but not nearly enough to get sugar into the cells. This leads to insane hyperglycemia, which causes a massive fluid loss, life-threatening dehydration, and hyperosmolarity. Those are your big clues. Okay, here's a modern clinical pearl for you. A patient comes in feeling nauseous, they're on an SGLT2 inhibitor, but you check their glucose and it's normal, or maybe just a little high. Why should DKA still be screaming in the back of your mind? Well, the answer is euglycemic DKA. That SGLT2 inhibitor is making the kidneys dump tons of glucose into the urine, which can totally mask the crazy high blood sugar you'd expect to see. But if that patient has some other stressor, like an infection, that insulin-deficient state can still kick off runaway ketone production. It's a classic trap you have to watch out for. So managing these crises really comes down to three key pillars. First, you hit them hard with IV fluids to get their volume back up. Second, you start an IV insulin infusion to shut down the ketone factory and slowly bring down the glucose. But third, and I absolutely cannot stress this enough, is potassium. Patients in DKA are potassium depleted throughout their entire body, even if the lab value looks normal at first. As soon as you start that insulin, it's going to drive whatever potassium is left into the cells. So if the serum potassium is already below 3.5, you must give potassium before you even think about starting insulin, or you could cause a fatal arrhythmia. Remember the order: fluids, check potassium, then insulin. Okay, so we've covered the fires you have to put out immediately. Now let's talk about the long game, the cardiovascular toll. And let's be clear, this is, hands down, the #1 cause of sickness and death in patients with diabetes. You know, this slide really gets at a massive shift in how we think about diabetes meds these days. We are not just chasing the A1C anymore. Just look at the GLP-1 agonists and the SGLT2 inhibitors. These drugs have proven benefits for cutting down heart attacks and strokes, keeping people out of the hospital for heart failure, and slowing down kidney disease. This is a huge deal. They aren't just sugar-lowering drugs, they are organ-protective agents. And that's why the guidelines now push for using them in patients who already have or are at high risk for heart and kidney problems. And look, it's not just about picking the right diabetes drug, right? It's about managing the whole picture. That means getting aggressive with a blood pressure target under 130/80. It means that pretty much every patient with diabetes between 40 and 75 should be on a statin, because diabetes itself is a huge risk factor.
And for anyone who's already had a cardiovascular event, aspirin is an absolute must. You have to tackle it from all sides.
But the damage doesn't stop with the big vessels in the heart and brain. That sustained high blood sugar is relentless, and it also goes after the tiny vessels. This brings us to the microvascular complications. That's sneaky damage happening in the eyes and kidneys, which often gives you zero symptoms until things are already pretty bad. I want you to burn this number into your brain. 30 milligrams per gram. That's the cutoff for an elevated urine albumin to creatinine ratio, or UACR. This is the very first sign of diabetic kidney disease. It tells you there's damage to the kidney's filters long before the creatinine in the blood even starts to budge. Finding this early is the whole reason we screen.
And the reason we hunt for that number is because we actually have a powerful, evidence-based game plan. If a patient has high blood pressure and a UACR of 30 or more, they need to be on an ACE inhibitor or an ARB, period. If the protein leak continues, we add an SGLT2 inhibitor, which we know slows down kidney disease. And if we need even more, there are newer options like finerenone. See, it's a clear, step-by-step approach to protect those kidneys. Now for the eyes. Diabetic retinopathy is the #1 cause of preventable blindness in working-age adults. And the key word there, the one I really want you to take home, is preventable. High blood sugar damages the tiny vessels in the retina, so we screen every year, because if we catch it early, we can get aggressive with glucose and blood pressure control. And for more advanced disease, we have incredible sight-saving treatments like anti-VEGF injections and laser therapy.
Okay, next up is the most common chronic complication, diabetic neuropathy. This classic stocking and glove nerve damage can be absolutely miserable for patients, not just because of the pain, but because of the devastating things that can happen when you lose sensation. So the classic presentation is what we call distal symmetric polyneuropathy. It starts in the longest nerves, in the toes, and just creeps its way up. It's so important to get that it hits both small and large nerve fibers. The small fiber damage is what causes the pain, the burning, the tingling, the zapping feelings. But the large fiber damage, that's what's truly dangerous. That's when you lose the ability to feel vibration and know where your foot is in space. A patient can't feel a rock in their shoe, and that can lead to an ulcer, infection, and, tragically, amputation. So what do we do about that painful part? Well, these are your go-to first-line options. This is high-yield stuff for your exams and your practice. You've got your gabapentinoids like pregabalin, SNRIs like duloxetine, and tricyclics like amitriptyline. And notice what's missing here. What's not recommended as a first choice? Opioids. For this kind of chronic pain, they are not the answer. And all of this really brings us right back to where we started. To fight back against all of these complications in the kidneys, the eyes, the feet, we have to be relentless with proactive screening and prevention. The whole name of the game is staying ahead of the damage. This table right here is basically your playbook. For anyone with type 2 diabetes, you start screening for eye, kidney, and nerve damage right at diagnosis, because we know that silent period has already been going on. For type 1, you start within 5 years. And look at blood pressure, that's an every single visit check. This is your practical guide for the clinic. Stick to this and you'll catch things at the earliest, most treatable stage. So, I'll leave you with one final thought to chew on as you go through your training. Since so much of this damage happens quietly for years before anyone notices, is our biggest challenge really coming up with brand new treatments? Or is it just making sure we diagnose people on time and actually use the powerful screening and prevention tools we already have?